Hello friends, welcome to a session of renal system. Today's session we will see approach for renal system, approach for proteinuria, approach for acidemia, approach for how you will approach in general, how you will approach for renal system. And even we will see treatment causes and diagnosis of hyperkalemia, as hyperkalemia is quite closely associated with renal dysfunction or renal failure. So we will see that hyperkalemia in the same session. So we will start with what will be the symptomatology of renal system. So the symptoms may be asymptomatic initially, asymptomatic hematuria, asymptomatic proteinuria, and that spectrum can start with proteinuria and go up to organ failure, like pulmonary edema or even renal encephalopathy, metabolic encephalopathy. So anuria means when patient is not passing, when the total urine output of last 24 hours will be less than 50 ml. So we will label it as anuria. Oliguria, when the urine output will be less than 25 ml per hour or 400 ml or 24 hours, then we can label it as oliguria. This both definition itself can be asked as a MCQ. Commonest symptom will be edema. Edema ranging from grade 1 to grade 4. Grade 1 is which will be which will be restricted to your pedal edema. It will progress proximally to thigh and even in anasarca or ascites. So fluid overload is a common presentation of renal failure. Sign and symptoms of uremia. Uremia is a name given to symptoms when patient is having high creatinine associated with, it may present with hyperkalemia, hyponatremia, or any CNS symptoms or any renal symptoms, any fatigability, and any other ranges of symptoms including skin symptoms. And even in chronic renal failure, patient may have renal osteodystrophy. So this is again one of the commonest complications of chronic renal diseases. Hypertension. Hypertension is very important because hypertension can be a cause of renal failure or effect of renal failure. So in uncontrolled hypertension may give rise to renal damage, and which will lead to renal sclerosis, nephrosclerosis, and so renal failure. And it can happen vice versa also. A renal failure patient most of the time in nephrotic syndrome, not in nephrotic. In nephrotic syndrome, those patients will have a hypertension. Pyuria is a basically microscopic finding when you will see a lot of pus cells in urine, and it indicates infection somewhere in renal system. Cast is also is very important part of urine analysis. We will see it in detail. What is the specific WBC cast and what is RBC cast and its relevance. So when you have a patient involving renal system, we can divide those patients in either this 8 to 9 syndromes. So these syndromes patient may be in acute or rapidly progressive renal failure. Patient may be of acute nephritis, that is nephrotic syndrome. Patient may be CRF, means chronic renal failure, where there will be a shrunken kidneys. Nephrotic syndrome, patient may be in nephrotic syndrome, or some patient, as I told you, may be asymptomatic, like asymptomatic hematuria in cases of IgA nephropathy, and asymptomatic proteinuria in case of nephrotic syndrome. UTIs, that is, he may have pyelonephritis or cystitis or urinary tract infection. Renal tubular defect, that is, he may present with renal tubular acidosis. Hypertension may be a presenting feature of renal disease. Nephrolithiasis, so multiple stones in kidneys. And urinary tract obstruction, so obstruction may be from external or in the intraluminal obstruction, maybe because of stone or some mass lesion. So this around 8 to 9 syndromes we need to put that patient in this 8 to 9 syndromes. So we will see what is the approach for acidemia. So Acidemia, as I told you, it's also called as uremia. And when suspected patient of renal failure, when you send serum sample for creatinine, and when you see the creatinine is high, so your question will be whether this is acute or whether it's chronic. And if it is acute, then what is it? Whether it's pre-renal, whether it's renal, or it's post-renal. And you need to find what is the cause. So we have an approach for azotemia, and we will see it on the board. So azotemia, that means increased serum creatinine. So you need to prescribe two investigation, that is urine analysis and UHG. And by UHG you will see what is the size of kidneys. So by UHG you can classify it whether it's CRF or ARF. When there is a shrunken kidneys, you can label that patient as a CRF patient, and we can confirm it by looking at low calcium or anemia or high phosphate. So here you can divide that patient as a CRF or ARF. When you have another patient, maybe acute renal failure, ARF. So we have an option whether this ARF is because of obstruction or whether it's because of non-obstructive renal failure. So obstruction, again we can divide it by help of UHG. So sonography, it will help first to differentiate between ARF and CRF, and second, it will also rule out post-renal cause of renal failure. It can lead to acute as well as chronic renal failure. So obstructive uropathy. Obstruction. So after here the job of sonography ends. Now we need to see what is the urine analysis. So urine analysis, it may be normal or it may be abnormal. And in abnormal, we have whether you are looking for any albuminuria, do you have any RBC cast? So RBC cast, WBC cast, or infection. Coming to a urine analysis of a patient of renal failure. So urine analysis, we can get RBC cast, we can get WBC cast, we can get granular cast, we can get tubular cast, we can get pus cells. So accordingly, by looking at what is the type of cast, we can fairly label or make diagnosis. So first, this all cast can be asked as a MCQs. MCQ can be asked like what is the significance of RBC cast. So if you get RBC cast, your diagnosis should be glomerulonephritis. RBC cast, glomerulonephritis. WBC cast indicates interstitial nephritis. WBC cast, interstitial nephritis. Granular cast, again interstitial nephritis, tubular nephritis. Pus cells indicates infection. Infection may be from maybe pyelonephrosis, pyelonephritis, or cystitis, or in lower tract like urethritis. And last option, you can see how much is the proteinuria. And here we have a different approach for proteinuria. With the help of proteinuria, you can divide those patients as a nephrotic or nephritic. If there is a severe proteinuria, you can say that patient is of nephrotic syndrome. So urine analysis is very important. So by looking at urine analysis, we have 4-5 diagnoses ranging from infection to glomerulonephritis to interstitial nephritis and even nephrotic syndrome in cases of proteinuria. If there is a normal urine analysis, so urine examination is normal and sonography is also normal. So how will be your approach in patient where creatinine is high? So obviously this is a case of acute renal failure. Acute, we have ruled out post-renal etiology by looking at sonography. So we have two options. It might be pre-renal or it may be renal. Pre-renal and renal. So here we can take a help of urine electrolytes. So we can measure what is the fractional excretion of sodium. We can measure what is the osmolarity of sodium, osmolarity of urine. What is the ratio of urea and create? What is the ratio of urinary and plasma creatinine? And we can differentiate renal from pre-renal type of acute renal failure by looking at urinary electrolytes. And we have that chart, you can see it in presentation. We have a very good slide it is indicating what are the findings in renal and what are the findings in pre-renal renal failure. For MCQ point of view, the commonest MCQ asks regarding fractional excretion of sodium. So when fractional excretion of sodium is less than 1%, the diagnosis of pre-renal should be considered. Fractional excretion of sodium, because pre-renal, the commonest cause of pre-renal is a fluid loss or pancreatitis. So our kidney function is normal as such. So by conserving sodium, our kidney conserves water and try to prevent dehydration. So fractional excretion of sodium will be less. Fractional excretion of sodium will be less in pre-renal, where in renal type, when the function of kidney is not normal, so that control over electrolytes will be lost. So sodium excretion will be more. So fractional excretion sodium will be more than 2%. And we have a ratio of urea and creatinine. In pre-renal, the ratio will be more than 20. And in renal, it may be in between 10 to 15. So ratio of urea and creat, more urea, less creatinine, it indicates pre-renal renal failure, acute renal failure. Urine sodium, as the same explanation for urinary sodium. The urinary sodium will be less than 20 milliequivalents per liter in pre-renal, where in renal type of renal failure, it will be more than 40. Urine osmolality, as kidney tries to conserve water, so osmolality of pre-renal renal failure will be more. So osmolality of pre-renal will be more than 500, and it will be less than 350 milliosmomoles of per liter of water. And last one is the ratio of urine creatinine and plasma creatinine, and that will be more than 40 in case of pre-renal, and it will be less than 20 in case of renal type of acute renal failure. So this, by looking at approach, we can definitely label that patient whether it's ARF, CRF, or and the etiology of ARF. So the other part of analysis is proteinuria. So if patient is having significant proteinuria, so what should be your approach? So approach for proteinuria. Proteinuria you can get while investigating a patient of renal failure, or in OPRI basis. If you are suspecting protein in the urine, you may prescribe deep stick examination. So initial point may be deep stick examination. So and deep stick examination is very specific, quite specific for albumin detection. So albumin can be detected on deep stick examination. This is also MCQ for your exam. And this deep stick examination may not detect proteins like Bain-John proteins, which is specific for multiple myeloma. So we need to go for 24-hour urinary protein. So we need to do 24-hour urinary protein, or you may do albumin creatinine ratio of urine. STAT, if we have option of collecting urine for one sample, then you need to prescribe ACR, that is albumin creatinine ratio of urine, single sample. And if you really see what is the secretion of protein in 24 hour, you need to collect urine for 24 hour. And then we can label that patient whether patient is having really whether patient is having microalbuminuria, or whether is in the intermediate phase, or the proteinuria is in nephrotic range. And so we can see what are the figures. So by doing 24-hour protein examination, we can label it as a microalbuminuria when the protein or albumin in the urine will be in between 30 to 300 milligram per 1.73 meters square over 24 hours. So milligram per 1.73 meters square per 24 hours. So if the range is in between 30 to 300 milligram, you can label this patient of having microalbuminuria. If it is in between 300 to 3000. So it's in intermediate stage, and if it is more than 3500 milligram per meter square of per 1.73 meter square over 24 hours, so this is a nephrotic range of proteinuria. So this is a very important MCQ asked many times in various type of exams. So microalbuminuria, we have two MCQs. Microalbuminuria will be defined as when the protein will be in between 30 to 300, and when and the nephrotic range proteinuria will be defined as when the protein secretion or albumin secretion will be more than 3500 milligram. So this was a rough approach for proteinuria, and in some cases, like in multiple myeloma, you may need to go for electrophoresis, like the patients of intermediate stage. So those patients may need for electrophoresis. So even multiple myeloma is a cause of proteinuria. So you should remember that point. So coming to, as we are looking for, as we are discussing what should be the approach, we have discussed what is the symptom, sign and symptoms. We have discussed what is acidemia, approach for acidemia, approach for proteinuria. We will see what are the imaging techniques which are helpful in our in renal system, and this is important more for your exam and even for your practical purpose and clinical practice. So two investigation, first is DTPA scan and second is DMSA scan. DTPA scan and DMSA scan. So DTPA scan, the long form is diethyl triamine pentaacetic acid. It is also called as a dynamic renal scan or renogram. DTPA, it is rapidly excreted by kidney, and we give intravenous DTPA, and with the help of gamma camera we took multiple images. So we have three phases: angiographic phase, renal phase and secretory phase. So angiographic, parenchymal and drainage phase. So we can get the physiological idea of angiography of that artery, of parenchyma of that kidney, and even for a drainage system. So it is helpful and it gives information about blood flow to the kidney. So angiographic phase. In angiographic phase, it will give information regarding blood flow to the kidney, and even it will give information regarding function of kidney. So what is the usefulness of DTPA scan and DMSA scan? I usually remember by mnemonic that this DTPA, please stand for physiology. So DTPA scan is important for physiological function of kidney. So physiological function, DTPA scan. And S stands for structure. It stands for anatomical structure of kidney. So I remember DMSA, S for structure and structure of kidney, and P for physiological function of kidney. So coming to DMSA scan, it is a static renal scan. DMSA, it is concentrated in parenchyma for longer duration. You give DMSA, you can ask patient to come after 3 or 4 hours and then take the images, and it will be accumulated in the kidney, and so we can get a good idea of structure. Will be the shape? What is the position of kidney? So structure of kidney will be so structure of kidney we can get by prescribing DMSA scan. So it is also called as a static renal scan. So we have a 2 MCQ, DTPA scan for physiological function and DMSA scan for structural and shape of the kidney. So here we have discussed the approach for renal failure, and we will see quite related topic, that is hyperkalemia, which is an emergency and it is quite commonly found in renal failure. It is also high yield point for your MCQ exam. So hyperkalemia will be defined as when potassium level will be more than 5.5 millimoles, and causes can be as potassium is an intracellular anion, the cause like metabolic acidosis will shift potassium intracellular to extracellular. So it may be one of the cause. Inadequate excretion, it may be a renal cause, it may be a adrenal cause. Advanced renal insufficiency and primary adrenal insufficiency is known to cause for hyperkalemia. And it's a medical emergency, and it can give rise to cardiac arrhythmias like sinus bradycardia, sinus arrest, slow idioventricular rhythms, and ventricular fibrillation, and even asystole. So ECG findings. ECG findings are important for your MCQ. ECG will be, so ECG in hyperkalemia. This is a normal PQRS pattern of normal patient, and in hyperkalemia there will be a loss of P wave. There will be initially there will be loss of P wave. The duration of QRX complex will be broadened. So duration of QRX become broader, and there will be a tall T wave, and it is called as a sine wave. The sine wave along with absent P with tall T wave is a characteristic of hyperkalemia. This is important for your MCQ. Diagnostic approach: by looking at urinary electrolytes and TTKG, that is transtubular potassium gradient, we can come to know what is the cause of hyperkalemia. Coming to a treatment, so hyperkalemia being emergency, we need to antagonize the effect of hyperkalemia on important cells like cardiac muscle. So the drug of choice will be calcium gluconate. So here MCQ, calcium gluconate is used for emergency as an emergency treatment for a patient of hyperkalemia. It doesn't shift potassium inside the cell. It only stabilizes the electrical activity of heart muscle, and the arrhythmogenic activity of those heart muscle can be controlled by giving calcium gluconate. So calcium gluconate for immediate antagonism of cardiac effect of hyperkalemia. This is again one question for your exam. The other approach for controlling hyperkalemia will be redistribution to the cell, and the fastest way of redistributing cell from extravascular to intravascular is insulin dextrose or insulin glucose drip. So a second MCQ, what is the fastest way of shifting potassium inside the cell? So your answer should be insulin dextrose drip or insulin glucose drip, and we need to add 10 units of insulin in 50 ml of 50% dextrose, that is 25 gram of dextrose plus 10 units of your insulin. This is a classical glucose insulin drip, and it can shift most of the potassium within 30 minutes. Beta 2 agonist, again not a beta 2 antagonist, that is not a beta blocker, but beta 2 agonist like albuterol, we can give it by nebulization. It again shift potassium inside from outside. Second approach will be IV. What is the role of IV bicarbonate? IV bicarbonate you should not give, or you should avoid giving bicarbonate, but you can give it when there is a severe metabolic acidosis with hyperkalemia. That is the only indication where you can give IV bicarbonate. Last approach will be to remove a potassium. We can remove it by your gastrointestinal tract, or you can remove that potassium by doing dialysis. So resins like sodium polystyrene sulfonate, we have a preparation of enema, or even we can take these resins orally, and that resin will try to absorb potassium through a gastrointestinal tract, and the potassium will be thrown out of the body. And as a last resort, the dialysis will be final treatment for hyperkalemia. So it was a discussion regarding introduction of renal system. We have seen what is the approach for azotemia, what is the approach for proteinuria, and what is the approach for hyperkalemia. Thank you.